Hi there, my name is Kimberly Benavides, and I'm a PGY1 at UNM in internal medicine. Our poster is about the unrecognized disease, cardiac sarcoidosis. So, a little background information. Sarcoidosis is a multi-system inflammatory disease characterized by non-caseating granulomas that can affect any organ. When it affects the heart, there is a poor prognosis as cardiac sarcoidosis can result in arrhythmias, heart failure, and complete heart block. Autopsy studies have shown that cardiac sarcoidosis affects up to 25% of patients with sarcoidosis, yet as few as 5% are actually clinically diagnosed. So, our case is a 43-year-old male with a history of biopsy-proven sarcoidosis. This is illustrated in Figure 1, which shows a non-caseating granuloma in the peripheral lymph node. He presented with productive cough, chest tightness, hemoptysis, night sweats, fevers, and chills. Labs showed an elevated troponin and BMP. A quant gold test was found to be negative. His CT showed pleural effusions. The EKG showed abnormal Q waves and an axis deviation. His echo, a TTE that was done, showed an ejection fraction of 20% and left ventricular wall motion abnormalities. So it was at this point that he had a cardiac cath done, which showed no signs of coronary artery disease. A SPECT contrasted CT showed no signs of inflammation typical for sarcoidosis, so he was started on therapy for heart failure and discharged home. Unfortunately, he was readmitted 1 week later for severe ascites, which was thought to be secondary to his heart failure. It was at this time that there became a high suspicion for CS, and a cardiac MRI and biopsy were ordered, and he was started on prednisone. His cardiac MRI ended up showing increased gadolinium uptake in the septal segment. This can be seen in Figure 2, which is a short axis view with transmural enhancement there at the inferior septal wall. So, for a discussion, this was a difficult case for a few reasons, which largely involved the diagnosis. So, for cardiac sarcoidosis, the only single definitive test to diagnose it is a myocardial biopsy showing the non-caseating granulomas, but even this isn't actually considered a gold standard given its low sensitivity. Many cases are diagnosed by meeting the criteria, which are shown, there's two of them, which are shown in Figure 3 and 4. The more commonly used one is the Figure 3, which is the Japanese Ministry of Health and Welfare criteria. So our patient actually met both of these criteria given he had a biopsy with a proven extracardiac sarcoidosis, the reduced ejection fraction, the abnormal EKG with the axis deviation, the echo showing wall motion abnormality, and gadolinium enhancement on his cardiac MRI. So as you can see, often diagnosing this must come from a comprehensive clinical picture involving the clinical findings and imaging. So the key points and takeaways that I would like to emphasize are the fact that cardiac sarcoidosis is often unrecognized, it is difficult to diagnose, and it also comes with a very poor prognosis. Clinicians must be able to combine clinical data and imaging to make the diagnosis and begin treatment. The mainstay treatment is corticosteroids, usually for at least a 6-week duration to help preserve the left ventricular function. So in summary, cardiac sarcoidosis should be considered in any patient with an existing sarcoidosis diagnosis who presents with signs or symptoms suggestive of cardiac involvement. Hopefully everyone learned something, and thanks so much.